Let's begin today's program entitled Delivering Success, Scaling Up Solutions for Maternal Health. That's incidentally the name of the report that we are launching today as well. So if you didn't already grab a copy, I would certainly encourage you to get one on your way out. We will be referencing it quite a bit today, and it is has a lot of exciting reading material in it. And there are other reports and materials outside on that desk as well that we'll be talking about and referencing. For those of you who don't know who I am, my name is Sandeep Bathala. I'm a senior program associate with the Global Health Initiative here at the Woodrow Wilson International Center for Scholars. Today's event is brought to you as part of the Global Health Initiative, or also known by its acronym of GHI's Advancing Dialogue on Maternal Health series, which works to address many critical and neglected maternal health topics and is generously supported by the Maternal Health Task Force as well as the United Nations Population Fund, UNFPA. As many of you know, I do believe that we have a lot of familiar faces here. The Woodrow Wilson Center is a formal memorial to our 28th president, the only president thus far to have achieved a PhD, and in his honor, we aim to bring the worlds of policy, practice, and academia together to better inform one another. Today's event, it's a really exciting event and exciting day. We are celebrating the latest iteration of the Maternal Health Dialogue series here at the center with UNFPA, the Maternal Health Task Force, as well as the Population Foundation of India. The series spanned 2012 and the first half of 2013. Since kicking off the series in 2009, is this on? Can everybody hear me correctly? Okay, was it going in and out? Felt a little odd. So since kicking off the series in 2009, we have convened 40 dialogue sessions on various topics with hundreds of panelists and participants from all over the world. They have joined the Wilson Center to discuss the challenges and real opportunities and solutions for moving the maternal health agenda forward. Earlier this year, in fact, the series worked closely with the Population Foundation of India, or PFI, to implement an in-country meeting, which was held in New Delhi on April 3rd and 4th. The April 3rd meeting brought together more than 70 experts to identify best practices, successes, gaps, and areas requiring focused interventions. Two of those experts are actually joining us today and are on my right and left, but I will introduce them in greater detail in a few minutes. That in-country meeting on April 3rd, like I said, the first day of it convened 70 experts. The second day, on April 4th, we did something that was really interesting, and I do believe some of you here in the room participated. We had a three-party video conference. We brought together the participants from India via video conferences to audiences here in DC at the Wilson Center, as well as in Boston at Harvard. The Maternal Health Task Force is based there and has a huge following there on maternal health issues. So participants joined from there as well. And that was a discussion where we really talked about the recommendations that were generated by the experts the day before. Generally, across the whole series, we've learned that we know a great deal about what it takes to prevent most pregnancy-related complications and deaths. This collective knowledge, coupled with political commitment and action, has led to a global reduction of maternal mortality of 47% since 1990. Yet despite these achievements, improvements have not been universal, and many countries and areas within countries remain behind. As you will read in the report and witness in today's discussion, there are many lessons and evidence-based recommendations that were presented during the past year and a half in this latest iteration of the series, and which we can excel to make progress, to advance the progress that has been made thus far. So thanks to our supporters, we're able to capture these strategies and synthesize these recommendations in a formal report. And we will use this as a tool to share the ideas with all of you today, but also to disseminate the lessons learned to maternal health agents, donors, and policymakers here in DC, across the United States, and abroad. So before I turn the floor over to the panelists, I have a few housekeeping comments that I want to make. I do want to thank the Center's Asia program for co-sponsoring today's event. I also want to mention that we're webcasting live today. So what that means for those of you here in the room, when we do come to the discussion, I'd ask that you wait for a microphone and our colleagues will. Speaking of microphone, it isn't consistently on, is it? Poonam, I'm going to steal yours. We'll share. Thank you. So use a mic, despite the fact that I apparently have not been. And please introduce yourself and affiliation. I also want to mention for those that are tuning in via the webcast, the presentations that our presenters will be using today or the reports that we are referencing are available online. And today's webcast will become archived. So I know that you are going to find this discussion so captivating that you're going to want to tell all your colleagues that didn't make it today to tune into that archived webcast to take a look at it. So. As I mentioned, wow. Okay. All right. Sorry about that challenge there. As I mentioned, I hope that you do have a copy of the report and that perhaps you grabbed a bio sheet of our distinguished panelists. So I won't go into their backgrounds in great detail because you do have that sheet. However, I do want to briefly welcome everybody and introduce everybody. We have Margaret Green, who's a co-author of the Delivering Success Report and director of Greenworks. We have Poonam Matrija, who's executive director of Population Foundation of India. We have Dr. H. Sudarshan, who's the honorary secretary of the Karuna Trust. We have Geeta Lal, the Senior Advisor for Strategic Partnerships, Human Resources for Health at UNFPA. We also have Jackie Caglia with the Maternal Health Task Force, Women in Health Initiative at the Harvard School of Public Health. And you, like I said, can read more about the panelists in your packet. So I will actually turn everything over to Meg now, or Margaret now.
Is it on? Thank you very much. It's a great pleasure for me to be here participating in the launch of the latest report on the Advancing Dialogue on Maternal Health series. My co-authors, Omar Robles, Sandeep Batala, and Lauren Herzer-Risi and I have a feeling of enormous privilege to have been in the position of distilling the knowledge and ideas of some of the world's leading experts on maternal health into this year's report. We've sort of just, our minds have been just channeling all of this information. As Sandeep noted, what we know globally has about what it takes to reduce maternal mortality has contributed to a very large reduction of almost 50% in maternal mortality since 1990. Yet huge inequalities exist. And the most underserved communities and marginalized women remain unable to access the resources, information, and services to ensure safe pregnancy, delivery, and recovery. And one of the main contributions and focuses of the Advancing Dialogue on Maternal Health series is to stimulate discussion to help leverage this collective knowledge and to reduce these glaring disparities in maternal health. I'm hearing the microphone going in and out also, and I would like to know if everybody can hear me all right. So this report is Delivering Success, Scaling Up Solutions for Maternal Health. The previous report in the series was called Delivering Solutions. From 2009 to 2011, the series highlighted priorities for policies, programs, and research to overcome social, economic, and health systems barriers to health. Delivering Solutions emphasized both the need to invest in improving maternal health and the need to identify the solutions across a wide range of areas. Recognizing the need to delve deeper into key issues and identify opportunities to maximize the scope and the scale of national responses, the Woodrow Wilson Center's Global Health Initiative hosted 15 additional events and engaged in various global fora in 2012 and 2013, and that's what you see before you is the content that comes from all of the experts who participated in those events. And what it describes is what it will take to ensure that our knowledge of what works is built into systems and applied at scale. The report strongly emphasizes the specific ways in which systems and services can become more responsive and can contribute to overcoming persistent social, economic, and health systems obstacles to women's health. And it also makes many connections with the global momentum in many of the related areas that contribute to improving women's health in family planning, in child marriage, and so on. The recommendations that emerge from the report cluster into 6 areas. 1, to strengthen data collection, management, and use. This includes tracking maternal mortalities and morbidities and investigating maternal deaths and then acting on the findings of those investigations. It includes collecting data and reporting on those data the responsibility of a broader range of stakeholders with varied perspectives and roles in the health system. And it includes monitoring the actual use of referral mechanisms. The second area is to prioritize equity in health systems' response to maternal health. This requires identifying and responding to the disparities of greatest relevance in a particular setting, and these, of course, most often occur along lines of geography, ethnicity, and socioeconomic status. The equity mandate also requires ensuring that maternal health is included in social protection plans that expand access to primary care services. And it calls for information and services to be tailored to the most vulnerable girls in particular, including married adolescents, minorities, and other marginalized groups. The third area in which the recommendations focus is an emphasis on quality and accountability in maternal health policies and programs. The participation of beneficiaries and the integration of a rights-oriented perspective into service delivery are 2 key components of quality and accountability. Promoting respect, nonviolence, and non-discrimination, and ensuring that health workers are trained in these principles in an ongoing way helps cultivate a sense of entitlement among beneficiaries, which in turn contributes to greater accountability as people demand what they know is theirs by rights. The fourth area is to ensure a reliable supply of essential medicines and health workers. Key life-saving medicines, especially oxytocin, misoprostol, magnesium sulfate, and manual vacuum aspirators, will always be central to maternal health and must be procured from certified manufacturers. Also central to strengthening supply is to train and assign responsibility for forecasting the supply, demand, and use of these medicines. In addition, physicians must be trained in identifying key maternal morbidities such as obstetric fistula and uterine prolapse and in responding to them. And the supports, the health systems support technical capacity and resources that are required to address these conditions have to be put in place. The experts who participated in all of these events also called for the greater engagement of a broader cadre of workers, including midwives and community health workers, to improve maternal health. And a final recommendation is to integrate mHealth technologies more fully into maternal health care. And of course, there are some very strong examples of how that's been done already. The fifth area is to integrate maternal health services across other sectors, in particular strengthening links between maternal health information and services, sexual and reproductive health, and family planning. And of course, you know, globally there's a huge amount of momentum around family planning, and newborn and child health with an emphasis on nutrition and HIV. The sixth area on which the recommendations focus is the need to invest in empowering women and girls and engaging men and boys. And this is in recognition of the persistent social constraints to maternal health. So the participants in the series emphasized asking women and girls themselves about the barriers to care that they face and addressing those barriers. And they spoke emphatically about the need to invest in girls' education, in child marriage prevention, and of course, there again, there's a global movement around child marriage and in mitigating the impact on very early marriage on girls. And the importance of informing women and adolescent girls about their right to live free from violence and the services available to them when they experience violence. At the same time, it's essential to engage men and boys as supportive partners and agents of change for women and girls in their communities. And there are many roles that men and boys can and do play as fathers, husbands, religious leaders, and so on. You can read about these recommendations in much greater detail in the report, but I wanted to take just my last few moments to emphasize some heartening connections I see with current happenings and debates in global development. Maternal health needs to be seen as central to the post-2015 development framework so that it is systematically prioritized in national investments. The distinguished colleagues whose ideas were distilled into this report emphasize 3 themes that are woven throughout the recommendations, resonate with the post-2015 principles, and could also guide the series going forward. The principles of universality, equity, and accountability. An exciting area of progress around the world is in the spread of universal health care in dozens of countries, and with many specifically tailored approaches depending on the setting. And maternal health is increasingly being recognized as a priority that needs to be covered by national plans. It's often one of the first areas that's included in national health coverage. The issue of equity has received a great deal of attention in discussions of development. While every woman is at risk for experiencing unexpected complications during pregnancy, childbirth, and following delivery, women's savagely divergent access and experiences are determined by social, economic, and health systems inequalities. And we're very fortunate that at the level of the post-2015 dialogue, there's discussion about the centrality of equity across many areas of development. And finally, the distinguished colleagues who contributed to this series raised the theme of accountability from many different angles, and the systems implications of accountability, from the need to collect data and analyze and report it widely, to the need to allocate and track budgets, and the need to engage program beneficiaries and communities in shaping and monitoring programs. So with all of this that's happening around maternal health, I speak to you today with a sense of guarded optimism that maternal health is increasingly viewed not as a specialty health issue, but rather as central to development. And what's more, the principles that are key to maternal health echo those at the heart of the post-2015 discussions and vice versa. So I thank you very much for your presence here today. I hope you share in some of my optimism and that it energizes us as we work to improve the health of women and girls. These efforts are right and they are doable. Thank you.
Thank you, Margaret. I think that was an excellent presentation and overview synthesizing all the key findings over the past year and a half. I did want to point out something that I didn't earlier, and that's the point that the report is drawn upon all the past events, which are listed online, including event summaries and the archive videos, such as I was suggesting that you recommend your friends to check out. I will also point out that the in-country meeting this time around had a partnership with the Population Foundation of India, but in 2011 we had partnered with APHRC, or the African Population Health Research Center in Nairobi, Kenya, and the variety of events that we've hosted, the 40 that I referenced, have spanned maternal successes and issues across the world. So do please check out the previous reports, our events online, and the archive videos. But now I'm going to turn it over to Poonam, who is our key contact and liaison for the meeting in April in India with the Population Foundation of India.
Thank you. Thank you to the Woodrow Wilson Center for not only inviting us today, but partnering with us to have what I thought and we all agreed was a very lively meeting attended, as Sandeep said, by 70 professionals from across India. It was the first time that I saw in India, Indian NGOs, along with government officials and donors. I shouldn't say first time, but it was after a long time. We saw a dialogue discussion with practitioners, along with government, on what were the key developments in the maternal health field, but also what were the gaps going forward. And we had the best of the academics and the field in the room. It was a stock taking where people came from a sense of experience and knowledge. So going forward, as I just quickly share the scenario in India and then talk to you about what that dialogue has meant for us going forward. It is the voice of these strong 70 people with experience that gave a lot of legitimacy, apart from our partnership with the Woodrow Wilson Center, and finally the conference that we had that you referred to, Sandeep. It was PFI's introduction to having a conference with the world via video. So it was our first time, and we are very excited to take that forward too. So before Dr. Sudarshan talks to you about the key recommendations, let me share some good news and not so good news based on the conversation we had at the meeting. So while there has been a marked decline in maternal mortality in India, from 301 per 100,000 women live births in 2003 to 212. So 301 to 212 in 2009, a period of 7 years. There's no denying that the international community played a very significant role through national, international advocacy. The Indian NGOs played a significant role, along with the national government, which played a very positive role in advancing the agenda. However, current interventions, one thing came up very early on in the meeting, that current interventions are inadequate because they do not focus at all on maternal morbidity. We have focused a fair amount globally and nationally on maternal mortality, but not ignoring maternal morbidity and women's health. So some women die, while for others, life is a living death experience. For every woman who dies, 20 women suffer from serious reproductive health morbidity. And I think a concern from the collective experience was overwhelming at this meeting. And that's something that leads to severe emotional, mental, psychological stress for women's health and women's being. There's a huge need for morbidity and equity was the second issue in the post-2015 Sustainable Development Goals to be considered. The most significant gains in India have been on increasing skilled attendance at birth. Birth attendance by skilled personnel have increased from 33% in 92-93 to 53% in 2007 and 2008. Also, more and more pregnant women are offered at least minimal care during the pregnancy. However, in spite of the increased skilled attendance, access to institutional deliveries, pregnancies continue to be a major health risk for women in many parts of the country. You know, women give a notice of 9 months before they deliver, and if we can't have our act together to save women when we all know that they are preventable, it is even having the maternal mortality at 201 for me and for all of us, I'm sure, is not anywhere near good enough. But if you only 50% of women in India receive 3 or more antenatal checkups. The situation is much worse if you look at the data by caste and tribe. The likelihood having received any antenatal care by a doctor is lowest for mothers who for scheduled tribes mothers, and highest for mothers who do not belong to a scheduled tribe or backward class. Also, for mothers in the lowest wealth quintile, only 23% receive any form of antenatal care from a doctor, compared to 86% in the highest quintile. So the second issue of equity, which has come out strongly in your report, came out, it was discussed and is an issue in India, that we are now talking about the last mile and seeing how you reach. And the last mile is the toughest to reach. It was easiest to reach the top quintiles. And if you take, for example, in an example that I'd like to share with you, that PFI did an inquiry on 29 deaths in Barwani district in Madhya Pradesh. There was 29 deaths within a period of 6 months. And when we went and investigated, we found 26 of the 29 were tribal women. And a district hospital is like a large city, or medium city at least. And we also found from the data in the National Family Health Survey and other surveys highlight that gaps in service delivery and healthcare for the most deprived and vulnerable are still tremendous. Not enough attention has been paid to reaching the poor, especially in the remote areas. And in spite of international recognition that family planning is one of the cornerstones, I think we have, for bringing down maternal mortality, we paid very, very little attention to. We had paid over the last decade when we were looking at maternal health, but it is changing. There is good news. Family planning is getting global focus, and it is getting some national focus. But I think the international community and the national community has really let down the women as far as family planning is concerned. It's better late than never. But globally, if let me share some data globally and nationally. So if we met the unmet need for women, then contraception use can avert well over all maternal deaths. I'm not talking about forced family planning or population stabilization. I'm talking about meeting the need of the women. And this finding has profound implications for policies on maternal and child health, and emphasizes the urgency of meeting the contraceptive needs of 32 million women in India whose needs are unmet. The figure is large. Again, access to family planning can reduce infant mortality by 10% and child mortality by 21%. So family planning, therefore, is a key intervention to prevent maternal, infant, and childhood mortality. And this was the first time, again, we were in a large discussion discussing the linkage between maternal health and family planning. So reproductive choice is one of the most fundamental human rights, and we see family planning in that construct. And by freeing women from incessant cycle of pregnancy, breastfeeding, and childcare, family planning represents a giant step forward towards gender inequality. And I want to underline that because unfortunately a lot of women's groups and feminists in our country too have seen family planning as a mere simple coercive approach to women's reproductive and sexual health. And I really think we have to do some thinking and get out of the mindset that many of us have been trapped in, if I may say so. And although we knew that the continuing failure or inaction addresses these barriers, to address these barriers has a very high price in terms of individuals and their families and their health well-being, the country's economic development, and to the country's economic development, we've not yet been able to estimate the cost of inaction. And now I'm going to come to a little bit about what PFI is doing about some of these issues given the debates and discussions we had at the Delhi conference and our ongoing work. And so one of the first things we decided after that meeting is to commission a book on the cost of inaction in family planning, to incomes, to women's health, to children's health, to the fact that, I mean, if 20% of the fertility is unwanted, why should any child be an unwanted child? Every child should be a wanted child, and the implications it has on economy, sustainable development, and so on. So we've finalized our concept note, and we are looking for a couple of good, or we haven't decided whether we're going to edit the book or find one or two authors who are going to write the book. And it's really been welcomed by the government of India. Second, in terms of community monitoring, accountability, community engagement, PFI happens to be one of the, for NRHM, it is the community monitoring agency. The National Rural Health Mission in India, which has focused primarily on maternal health and can take much of the credit for bringing down maternal mortality. One of the 5 pillars of that, of the National Rural Health Mission, which was launched in 2005, is community monitoring and community mobilization and participation. And PFI has the privilege of being the secretariat as appointed by the government of India. And so we've begun to look at many, many more indicators on maternal health, and including family planning, age at marriage, in the community monitoring, which we are in the process of scaling up. We did pilots in 9 states in 1,000 villages, and now we're scaling up across the country. And we find that women's engagement and involvement, it almost erupts into a movement, because they know best what they're experiencing and what they want. And we've got evidence for it through some of the data in terms of the changes that have come in women's participation. In terms of reaching the unreached, we've got the language on the government programming and thinking. And so suddenly we have found government waking up, because we also brought in the evidence and the data to realize that the last mile has not been reached. So there's a big push and strategic dialogue happening at the policy level within the country on reaching the last mile, so greater equity concern. On morbidity, it is the first time, I think, not only the development community woke up in a big way that maternal morbidity has been neglected. When I say the development community, I'm referring to largely the women's health community. But the government is absolutely supportive and beginning a conversation on how do you bring morbidity and looking after morbidity within the public health program in India. Reaching out to communities in terms of comprehensive approach and linking maternal health with other aspects of their health. There has been much debate and discussion on how do you change behavior, and how do you get to the unreached women and men in the community on the linkages, and to look at women's health in terms of nutrition, in terms of family planning, in terms of access and so on, in a more comprehensive way. So one of the things that we have all discovered is, and there's global evidence, that behavior change communication one-on-one has not been very effective, because if you have community health workers doing behavior change communication on issues like age at marriage, when their own children are getting married at a very early age and when their cultural constructs is different, you've got to look at strategies on behavior change communication where you're changing mindsets and society's mindset. Also, we have found that individual behavior is very difficult. It's very difficult to exercise change when the mindsets are different. And we've learned much from Mexico, Brazil in some of the communication they've had through television and other programs. But we've learned much actually when we began to work on this behavior change communication from South Africa, the Soul City model. So PFI, along with the government of India, is launching a 4-day-a-week serial on television. It's going to be entertainment, but in that we are integrating all the issues that you have covered in your report and we talked about at the Delhi conference. And so this program is going to be launched in January, and it's going to be not just on television. One second, am I?
A few more minutes.
Okay. I get very carried away with this new program and initiative that we are about to launch. So I just want to make sure that I wasn't taking other people's time. So we have 4 days a week prime time on Doordarshan, which is the government channel. But the advantage of the government channel is that we are reaching, it has 80% penetration in India and 20% viewership amongst the poorest women because it is free across the country, and it's going to be in across the country in 7 regional languages. It's going to be dubbed also, and it is the first time that on these issues we are going to have entertaining serial, and we have studied very closely what happened in Soul City and what happened in Mexico and Brazil, the programming there, but it is in a women's empowerment framework. So for those of you who don't know Hindi, I will translate, but the serial is called Main Kuch Bhi Kar Sakti Hoon. I can do anything, and it's gendered. Karti is woman, Karta is man. So I can do anything, and the byline is, मैं अगर इंसान को जन्म दे सकती हूँ, तो मैं कुछ भी कर सकती हूँ. If I can give birth to a child, insan is a human being, yeah, not child. I can do anything. So it is, that's the byline. And we are positioning giving birth to a child as a huge achievement, but an achievement that has lots of risks associated with it. And also, we're not ready to look after women. We also have a situation that women want to regulate their fertility. The wanted fertility in India is 2.1%. And this is the poorest of the women. This is the average across the country. And for those who say, oh, we can't have a two-child norm, if women or families across the country want 2.1 children, we have no business to not serve them. So this is what this whole serial is going to be about. And I must say that we learned much from the rich discussion in terms of both the practitioners like Dr. Sudarshan and academics who came to this conference, as well as the policy makers. But I do want to say here, we also discovered that on maternal morbidity, we have very little information how we work. So before I sign off, I do want to say that that's something I would like to appeal to the international community to really think about. The maternal mortality agenda is incomplete without a maternal morbidity agenda. At this consultation, we found that in India, there are only 2 studies on maternal morbidity, and there's very little in the world too. And I have a colleague from MacArthur Foundation where I used to work before, sitting here, Sharon. Sharon, both those studies were supported by MacArthur Foundation. So the only research we have on morbidity is that in India, and also I believe globally we don't have much evidence. So let's work towards making sure that women don't die, and if they do live, they don't live living deaths. Thank you.
Thank you, Poonam. I really appreciated your comments on the impact of our collaboration on your work and the larger community. And I actually do want to say that your impact is probably going to be greater than you can imagine, because the number of South Asians that watch Doordarshan that are not based in India, including my parents, are now going to tune into that serial as well. I'm going to certainly insist on that, and I think it is going to be of a much higher quality than some of the stuff they watch now.
I promise that.
I'm already in trouble with them. I'm always in trouble with them. So there were a lot of themes that came out of the discussion in Delhi, so I'm now going to turn it over to Dr. Sudarshan to talk to us a little bit more about those sessions.
Thank you. Basically, I'll be talking, as was said in the meeting in Delhi, it was a combination of experts and the practitioners, which was ideal combination, I feel, and thanks to Wilson Center and PFI for organizing that. So the outcomes of that, I basically, very briefly, Karnataka Trust is a service provider. We cover about provide healthcare to 1 million population, both maternal and child health. We work in 5 different states, mostly the backward states, northeast, and also in southern states. We run primary health centers and first referral units also. We have about 2,000 health workers and 100 doctors, including 1,000 ASHAs. I just looked at the cost effectiveness. We spend $3 per person per year is the cost of total primary health care in India, which we are spending. $3 per person per year. So with that, we are able to achieve some of this. So I will be talking from that perspective. I was also the chairman of the Task Force on Health and Family Welfare for Karnataka State, and we made concrete recommendations to improve the health system, including the maternal and child health. And in that, we found corruption as one of the major issues. And I was also, as an ombudsman, as vigilance director, worked with the ombudsman organization to prevent corruption in the health services. So based on all this, I will be talking about how the recommendations can be used in these good recommendations of the wonderful document will be a good tool for us to use it for policy and also in the implementation of the various government programs. So all these programs we do is under the public-private partnership. Now coming to the strengthening the data collection is their management and use is very important, especially tracking we have that mother and child tracking system, but it needs to be strengthened. But morbidity is not tracked at all, so we need to have morbidity included in that. Secondly, we believe in triangulation of data. There are 3 sources of data in India now. We have the government's health management information system, which is not very accurate and not being very much effectively used. Then we have the national survey data, which happens SRS, the sample registration survey, which is more authentic data which we get. And the third, which we have added now, is the community monitoring data. A lot of report card system has been evolved in several states, so we have the community monitoring data. So if you can triangulate all these 3 data together, I think we'll get somewhere closer to reality. So triangulation of data is also very important. Second, equity in healthcare responses, reaching the unreached. Poonam has said, especially Karnataka Trust reaches out to, and the partnership with the government is to, where government cannot reach, we take those primary health centers. We work in insurgency areas, in Maoist areas, and take up that challenge and see that the services, maternal health services, are provided in that area too. So the equity issue is also rural, tribal, very remote areas. We need to take care of that. Quality and accountability is very important, and quality in maternal health has been a great challenge. We have what's called a National Accreditation Board for Health. It used to be only for hospitals. Now it has been extended to primary health care and maternal health in the primary health care approach. I'm happy to say Karnataka Trust run primary health center, except in Gujarat, which they had got. The rest of India, we were the first to get an ABH accreditation for the primary health center. And we have evolved quality tools, indicators for maternal health and child health, and also family planning indicators for providing good quality services. So second is of course, the patient satisfaction is the most important in that quality indicators. Accountability, a lot needs to be done. especially maternal health. When I was working as the vigilance director for 4 years, the most difficult, the corruption is basically at the procurements of various procurements, drugs and equipment. Second source of corruption is at the hospital level for various services provided. That's very, very shocking, and I quote this example. When one woman had to put her Mangalya Sutra, that's a sacred thing, and get 2,000 rupees, paid 1,500 rupees for the doctor, and another 500 rupees for the additional drugs which they prescribe. So this was a very, very pathetic, very painful story. So first time in the history in Karnataka, we made the doctors and the nurses who were taken bribes from this for these providing free services. We made them pay back the bribe amount, and we are trying to influence the whole system to get up to more transparency and accountability mechanisms. It's a long way, but we are trying to do that. And procurement also has been made. Now we have systems to control it. And just to say, with the same budget in Karnataka, we are able to get double the quantity of drugs with a integrity pact with the pharmaceutical companies. They don't have to bribe anybody. They bring down the rates of these essential drugs. So the accountability mechanisms, I mean, there are many other stories which I don't. Once the child is born, baby is born, to show the baby to the siblings outside, waiting, the male baby 250 rupees, female baby 200 rupees. That's the type of bribe you have to give. Male baby is cheaper than the female baby is cheaper than the male baby. So I feel good governance in healthcare can give a quantum jump in health outcomes, especially maternal health, and we need to do that. Now, essential medicines is a very great challenge in the country, and we need to provide that. There is a big move to improve the amount allocated resources for essential drugs, including maternal health. And the logistics are very important, procurement and distribution. And we didn't have a mechanism to see whether these essential life-saving maternal drugs are available in all the health centers. So we are working on a model with Logistimo, where we have, for Karnataka Trust and PHCs, in the head office we have, if a emergency oxytocin is not available, it comes as a red indicator. So we are trying to do this, extend it to the district level in Karnataka. So hopefully this model, if every district health office has this, and they can alarm the particular center if they don't have an essential drug, so will be a very great information technology which can help us in monitoring the essential drugs. Human resources is a very important aspect. Of course, also the morbidity area, the fistulas and prolapse are the major issues. And now within the free services provided as a package, now we have the insurance mechanism in Karnataka to take care of these morbidity issues also. Now the HR issues, ASHAs, health workers, also challenges. We don't get specialists in the very backward states in India. So we are now looking. We are running an FRU with an ordinary MD, MBBS. We call it MBBS, with 4 months training in emergency obstetric care. She is doing very well. She does the C-sections. So we need to look at the nurse obstetricians, doctors becoming obstetricians without the full 3-year course of post-graduation. Now the integration of maternal health with other sectors is very important. The child health, the family planning, nutrition, HIV/AIDS, all these need to be integrated. That's the advantage of our comprehensive primary health care approach, where we integrate all of them into one integrated comprehensive primary health care. Empowering women and girls is the most important thing. As Poonam said, we are also part of that. How to use the community. We have village health and sanitation committee, the mothers committees, where they are empowered to do their own planning for their particular village. And then also they take care how they can handle the emergencies. They also look at what responsibilities they can take, and also monitor the services provided to them. And that's a very important tool for accountability also. First time there is a report card system. Openly they are able to tell, we were supposed to get this incentive, but we got only this much and we had to pay the bribe. When we went to the primary health center or the FRU, the specialist was not available. All these are coming out in the community monitoring system. Now, so empowering women to manage their own health is very, very important, which needs to be done. So finally, I think universal healthcare, where many of the states are moving in India, equity and accountability are the very important issues which we need to take forward. So again, I would say thanks to this wonderful document, it will be very useful both for the practitioners and also to bring about policy level changes both at the states. In India, states are quite autonomous and they have to make the policy decisions. And at the national level, it will be a wonderful tool. Thank you.
Thank you, Sudarshan. I think it was particularly interesting, and I'm sure my colleague Lauren probably feels the same way, to hear about your work as it relates to the plenaries and breakout sessions that we had in our meeting in Delhi. I think now we can just move right along now to Geeta, who's going to talk a little bit more about UNFPA's work. I think we're
Yeah,
actually
so
going
it's
to start
working,
with a
yeah.
film.
Yeah. Good afternoon, everybody. It's an honor and a privilege to be part of this wonderful series of dialogue on scaling up maternal health initiatives and advancing maternal health that have been going on now for a few years in collaboration with the Woodrow Wilson Center and the Maternal Health Task Force. I'm going to start with a little film. This is about the work that UNFPA is doing under the Maternal Health Thematic Fund. So that will give you an insight, because I've been asked to talk about what UNFPA has been doing in relation to the recommendations that have come out in this wonderful book. So let's start with a brief film, 2-minute film. So, much has been done, but much, much more remains to be done. I guess that's one of the key messages we get from the film. And lots of good is happening around the world, but lot still remains to be done. Maternal health is at the front and center of UNFPA's mandate. This is the first slide that you see is the UNFPA's strategic plan, which has just been approved last week by our executive board. And if you look at the bullseye, that is about MDG's targets A and B, and all about maternal health and about equity in maternal health. The target groups, the key target groups for UNFPA are adolescents and women. And even amongst women, it is first-time young mothers or lactating mothers. And the outer ring is, we have a very integrated system of approaching programs. So we'll also look at population dynamics, which is data, because that is needed for program planning and advocacy, human rights, and gender equality. So that forms the basis of our programming. So that, in a nutshell, is how the UNFPA is programming for the next 4 years, 2014 to 2017. Again, if you look at our basic priority areas, the guiding principles are quality, equality, and accountability. So whatever we do, whatever programs we now take on or continue with are going to be focused on these three key principles. The report has also said the same thing, that we need to focus on quality of care, we need to focus on equality, reaching the most underserved, and also look at issues of accountability, which the previous speakers have amply pointed out. So how I've framed this discussion is I've taken the key recommendations that have come from the book, and I'm going to give you some examples of the work that UNFPA is doing in each of those areas. So the first recommendation that is there in the book is about strengthening data collection, management, and use. So UNFPA, actually our name is United Nations Population Fund. So we are heavily engaged in censuses and surveys globally. And currently we have been engaged in supporting the 2010 round of censuses. We also support a lot of DHS surveys. We have completed about 34 emergency obstetric newborn care needs assessments, along with costed operational plans, which look at district level micro-planning in countries. 24 have been completed, 10 are in various stages of completion. 8 midwifery workforce assessments that really look at human resources for health as to how they are scattered, what is the need in a country. This is going on in 8 countries which account for more than 60% of global deaths. These countries are Afghanistan, Bangladesh, DRC, Ethiopia, Mozambique, India, and Bangladesh. These are the countries that we are focusing on. And next year, we are going to take out the second State of the World's Midwifery report. The first one was launched in 2011 at the Triennial Congress of the International Confederation of Midwives, and that targeted about 58 countries. And UNFPA actually managed to drum up a lot of policy level support using that report as a basis, because that was the first report of its kind on midwifery services that are there available or lacking. And so the next one, we are trying to align it with 78 countries, which are also the countdown countries. The other thing that we are doing is, of course, there's a lot of work that UNFPA does around morbidities. So we have also prepared a map, fistula map, about global map, which shows where these services for fistula repair are available globally, which is actually very useful because we didn't know where the services were available before this. The next recommendation is prioritizing equity in health systems response to maternal health. And clearly, that is, if you saw the that's correct. So you saw the first slide. Reaching the most marginalized is our goal. And we are trying all kinds of programs and, so how to make it more, right from generating demand to engaging communities to engaging with faith-based organizations. First-time young mothers, lactating mothers are one of our key target groups. Adolescent, youth, minorities, sex workers, people living with HIV, and persons with disabilities are also going to be one of our focus target groups. We have an adolescent girl initiative, which is currently in 12 countries for 5 years, starting in 2013. And through this initiative, we aim to provide a minimum healthcare package, including contraceptive services and HIV counseling to all the adolescent girls who are part of that initiative. There is, and in fact, this is my favorite because I'm engaged in it, I guess. For equity and access, we have launched a very, very innovative partnership, public-private partnership with Intel Corporation. This was done just last year, and we are also collaborating with JPIGO and WHO. And what we are doing is we are trying to create highly interactive multimedia e-learning modules on all basic life-saving functions. 4 modules have already been completed on pre-eclampsia, eclampsia, postpartum hemorrhage, obstructed labor, and post-abortion care. And these 4, I guess all of you know, would account for a vast majority of maternal deaths that happen. The other modules are in the pipeline, and these are on sepsis, essential newborn care, and family planning. And we strongly believe that if we have all these in place, and we can get these out there, because trained health workers will need to be trained in the use of low-cost tablets. And we know that technology is spreading faster than we can blink. And it's an opportunity out there that we need to grab with 5 billion users, mobile users, of which 4.5 billion are in the developing world. It's an opportunity that we cannot ignore anymore. It's either ignore or either get onto the bandwagon or be left behind. The same program, how will it help us achieve equity and access? Is because once the health workforce is equipped with low-cost tablets and they have been trained to use these low-cost tablets, they will also track all the patient visits, all the antenatal care, all the postnatal care, all the vital data registration. So it is like a comprehensive package that we are trying to promote. Right now we are in the development phase, so this will require collaboration with everybody in the room and beyond, and way beyond, to get this out there and get it moving. Fistula campaign, again, equity and access. Fistula, if there's a beautiful photograph which also always touches me, and I was also responsible for the fistula campaign in Asia a few years ago. In a world of unequals, the most unequal of unequals are the women with obstetric fistula, and that is so true. Death is preferable to getting a fistula during pregnancy and childbirth. And UNFPA, you saw some of the slides in the previous film, has been doing a lot of work in treating morbidities, 20 plus women who get morbidities for every woman who dies. Again, there's another program when we talk about equity and reaching the most marginalized. We have a program in 12 countries on female genital mutilation/cutting. 3 million young girls go female genital mutilation every year. And under this program, which is jointly conducted with UNICEF, we have made a good amount of progress. At least 8,000 communities right now in Africa have declared that there will be no more female genital mutilation and cutting, but much, much more needs to be done. Looking at accountability, there are lots of ways of promoting accountability. One, of course, is advocacy. There's no other way of, advocacy. We have to continue to advocate. But one area where UNFPA is investing heavily, and as we go forward, it'll just increase, is on maternal death surveillance and response and verbal autopsies of deaths. So trying to track what are the causes of maternal deaths and try to hold people responsible or avert those causes of maternal deaths. Again, through this same program that I mentioned with Intel partnership, we will be able to track, again, accountability. The health workers, once they're trained and they're out there in the field, we want to also make sure that they're doing their job. So all the health workers out there are not necessarily doing their jobs also. So this will also enable us tracking of that. So that's why I put that in accountability. We have a huge midwifery program, which I'll be talking about in a slide ahead. But under that program, we are looking at midwifery regulations. Just like physicians have regulations, so do midwives and frontline healthcare workers. They need to be regulated too, because they're dealing with human lives. So those lives need to be saved, and they need to provide safe and quality delivery. The other point, this is actually a dual, this recommendation comes accountability for quality of maternal health policy and programming. So we also have quality of care, again, training health workers to global standards. So under the midwifery program, again, we are trying to train people, midwives globally, according to global WHO and ICM standards. So it's not just any kind of training. We want to make sure that they are competency-driven trainings, that they have the skills, once the midwives are trained, that they have the skills to perform the functions, at least the life-saving functions, the core life-saving functions according to global standards, and that they're authorized to do so. So it's not just okay that you are trained, but you need to be authorized to practice those functions. Again, the next is access to all essential quality commodities. This is, again, improving quality. Helping countries respond to the EMOC study results. You saw in the film, and I mentioned, we've completed about 34 EMOC needs assessments, and as these are going on, more countries are asking us to conduct those, because those are really detailed level assessments. They literally do a MRI of the health system in a country. You know, what are the facilities available, what are the supplies, what are the healthcare workers, what are the needs, what is missing. So the governments are finding it extremely useful. So we started with 12, so it's already become 34, and the demand is increasing. Again, integrating, I've put nutrition here, but maybe it should be part of integration. And fistula repair capacities also, we are trying to increasingly address. Because there are 2 million, there's a backlog of about 2 million cases. We've done about 34,000 repairs, which is roughly half of the global repairs. Colleagues in gender health and others have been doing an amazing job too. But lots need to be done. Ensuring a reliable supply of essential medicines for healthcare workers. This is another key recommendation that has come out of the report. And UNFPA is really proud that it has been playing a major role globally on this aspect. UNFPA has been the largest contraceptive provider for the public sector. We have a global program on reproductive health commodity security that started in 2006, 2007, and still going, and it has been approved for the next strategic plan as well. This is also looking at essential medicines, all essential medicines, so not just contraceptives, but all essential medicines, equipment, and supplies. And we are integral part of the UN Commission on Life-Saving Commodities, which is part of the Every Woman, Every Child strategy, the Secretary General's strategy, and responsible for recommendation 6. I think that's together with USAID on supply chain and awareness. We are also leading with USAID on 3 maternal health medicines, which are key life-saving medicines: misoprostol, oxytocin, and MAC sulfate, to tackle PPH, postpartum hemorrhage, and preeclampsia, eclampsia. And we are also the lead agency on female condoms. So again, when we talk about female condoms, we are also talking about women's empowerment. Since the recommendation includes health workers, I mentioned we have a midwifery program together with the International Confederation of Midwives that is now in 30 countries. And that program, we are looking comprehensively at midwifery education. Under education, we are looking at the schools, the tutors, do they have the capacity? So building right from teaching capacities to strengthening the clinical skills, making sure that the curriculum is competency-based. Then midwifery regulations, so to ensure that there are right policies in place to govern this whole profession. Giving the midwives a voice so they can promote their profession. So midwifery associations are important. We have established about 30 associations in the last 4 years at national and subnational levels. And policy and advocacy is really key. Actually, it's across the board, so I won't even get there, because we cannot achieve anything without a lot of policy and a lot of advocacy. Integrate maternal health services across sectors. I mean, this is a no-brainer. We all need to do that. We all know why it makes perfect sense. And of course, we are focusing also at, my colleague pointed out, UNFP is also promoting integration at the primary healthcare level. Investing in empowering women and girls and engaging men and boys, again, it sounds easy, but it's not so easy. But we are doing it and making some progress. And one way that we are doing it is through culturally sensitive approaches to programming and engagement of faith-based organizations. And we have a very, very large network of faith-based organizations that we work with. In fact, I feel like citing an example. I think in Afghanistan, I may have forgotten, but I think they're still there. There's a Ministry of Vice and Virtue that still exists, perhaps. And the religious leader is more powerful than God himself. I mean, forget the development world, he's more powerful than God himself. Talking about family planning, if you engage that person, if it goes out in their Friday prayers, if we put messages on family planning in Friday prayers, that's what UNFP has done in some countries, they have such an impact. That means that word is coming from God's mouth. So it does not matter. We can, so it's really a big bank. It's better to target, find a few initiatives and find what has impact than to try 100 different things. So culturally sensitive approaches and inclusion of faith-based organizations. Violence against women, again, a lot of advocacy that we do for violence against women. Female genital mutilation is a kind of violence. I mentioned that program. Ending early marriage, it's huge. We've managed to get resolutions around it. Prenatal sex selection, UNFP has been doing significant amount of work in India, China, Vietnam, and engaging men and boys. Again, counseling for couples, etc. There are lots and lots of initiatives. Sustainability. In fact, I think this should be first, this slide. It's useless having a program. The more you work in the development sphere, you realize that unless you start thinking of sustainability when you start a program, that's why we fail and we waste so many resources. And it's really on our minds. And one thing we want to do around sustainability is, of course, partnerships. We cannot do it alone. There's too much to be done, and too many people doing it, and there's no coordination, which is a fact. So we need to expand partnerships. For us, it's, of course, the H4 Plus. I think most of you would be knowing. Anybody doesn't know H4 Plus? H4 Plus is UNFPA, UNICEF, WHO, World Bank. These are the health agencies, and it has been expanded. A plus has been added because we include UN Women and UN AIDS to that partnership. Then there's the commodity commissions, there are regional institutes, there are civil society organizations and private sector. So pretty much everybody that we want to expand partnerships with. Consolidation. Again, another problem is being thinly spread out. We get a pot of money, there are a lot of demands, a lot of initiatives, and we want to start consolidating so that we can show better and more more significant results. And national capacity building. Again, it's difficult to say which bullet should come first. I think the development aid that goes to a country is insignificant. It's peanuts. In fact, it's smaller than a peanut. It's the national governments. The day the national government comes across and says, okay, we will take this on, they don't need our resources. And I think that's when we can say that we have achieved our goal, when the national government says, we do not need you anymore, we can do it ourselves. So their engagement, their resources are absolutely, absolutely key. And I think I have already told you about this, that technology offers solutions. We have to find innovative approaches, both to processes, really when we talk about what sort of programs are we promoting or requesting developing countries, we have to make sure that they are appropriate for low resource settings. So for instance, I think many of you might have seen, we have this partnership with Leerdal and Jipaigo. And with USAID funding, they have produced these beautiful midwifery training models. Each of those training models now the cost in a developing country is $250. And before that, we were using those big Noel training models. Guess what the price was of one training model? That costs about $20,000. typically. So that's the kind of difference. And there is no maintenance in the country. After sales service is not there. So you need low resource setting appropriate technologies in products, in processes, and in partnerships like what we have. And you'll be hearing more about it in coming years. We hope, we pray, and that you'll join us. And that's about it. So thank you very much for listening in. Thanks for organizing this.
Thank you. So now we'll have Jackie help conclude today's event by talking a bit more about where we're headed next.
Thank you, Sandeep. Good afternoon, everyone. It's such a pleasure to be here representing the Maternal Health Task Force. It's truly a highlight of my week. I know that Anna Langer and Mary Nell Wegner and many of my other task force colleagues would love to be here as well, and they send their regards. So I was asked to offer some reflections this afternoon to summarize a bit of our discussion today and to look forward to the fast approaching deadlines on the Millennium Development Goals. After all, this is a big week within the United Nations, a week during which the path to the post-2015 MDG agenda will be further etched out. So I think we have to start by reflecting on how far we've come. As you all well know, there were an estimated 535,900 maternal deaths less than 10 years ago. Since then, maternal deaths have declined. Between 2005 and 2008, they declined by 35%. In the 3 years following, they decreased by an additional 20%. This nearly 50% reduction in maternal deaths has really created a sense of optimism in our field and in the development community in general. Though, as my colleagues have mentioned, these global figures mask some inequalities and disparities among and within countries. The downward trend is still undeniable. And for the first time, it really feels like the elimination of preventable maternal deaths is an achievable goal, although a challenge ahead. We have to continue as a community to document what works and to mobilize our community towards new commitments and more rapid innovations. As you also all know, the 5 main causes of maternal deaths are the same everywhere and have been for many years. Women are still dying of the exact same reasons that they were dying of years ago. Unlike other aspects of healthcare and our healthcare systems, we actually know exactly what needs to happen to save these women's lives when one of these 5 conditions appears. We need to get women the care that they need quickly, in ways that are appropriate, from skilled providers, and with the resources that they need in the context of supportive communities. In order to improve maternal health, we must also go beyond these main direct obstetric causes of maternal deaths. As my colleagues have alluded to, we need to really broaden our focus to include comprehensive, high-quality health care for women and newborns, which means that we have to make sure that our delivery systems are integrated. We have to ensure that women receive the critical services that they need during prenatal care that enables them to have a healthy pregnancy, and that they're protected from complicating factors that may arise, like malaria, HIV, and AIDS. We really have to ensure that our health systems are comprehensive and integrated so that a woman need not choose between a checkup for her newborn and a postnatal checkup for herself. As has been mentioned, a focus on quality of care is key. We need to focus our efforts on making sure that we're offering the highest quality of maternal health care that is possible. This care needs to be safe, effective, efficient, timely, and equitable. Another critical dimension of quality care is compassion, making sure that care is patient-centered and that patients are treated with dignity and respect as they seek care across the RMNCH continuum in times of both health and vulnerability. We have to also bear in mind that providers, our workforce, are also people. We have to care for our workforce, especially as we increase the demands on their time and ask them routinely to do more safely and creatively with fewer resources. As has been mentioned, data really are our building blocks, and they're the building blocks on which we can accomplish our goals. We need better systems of measurement related to maternal and newborn health outcomes and also related to how our health systems function. We need to concretely increase capacity within the field for monitoring and using data in real time for decision making. There are promising practices related to data management, particularly related to the use of mHealth technology, or examples that Geeta was just referring to, that we need to pay close attention to and look to bring to scale. Finally, we must acknowledge and celebrate that at its core, what we're really talking about to improve maternal health is empowering women and girls and needing to engage more men and boys in this in order to bring these fundamental changes about. When we work to redress inequalities and power dynamics, when we truly value women as productive members of society because of and beyond their productive role, we will accomplish this change. With all of that in mind, while we must keep a forward look on the future, we have to not lose sight of our current targets. There are more than 800 days remaining until the end of 2015, 829 in fact, depending on how you count today. And women are still dying from maternal causes at a harrowing pace. So I'd like to echo Margaret's guarded optimism and Poonam's call for women's engagement and cultural shifts, and Dr. Sudarshan's sharp visions for accountability and good governance, and Geeta's inspiring examples of the power of consolidating efforts in technology and couple it with a sense of urgency. We have to protect the progress we've made as a community and push for more. We have to believe in and invest in this future, and we have to make every one of these remaining days count. Finally, I encourage all of you to join in this lively dialogue related to the post-2015 targets. As part of the Maternal Health Task Force role as a neutral convener within our community, we're curating a series of blog posts on the topic, aiming to amplify the diversity of voices related to our future goals as a community. We welcome your contributions, and we look ahead to our next year of partnership with the Woodrow Wilson Center and with UNFPA on the Advancing Dialogue on Maternal Health series in the hopes that we'll be able to continue these discussions in this very room. Thank you.
Thank you. I feel like there's no need for me to conclude because Jackie just took the words right out of my mouth. I was going to say that I'm really excited, especially after hearing your remarks, to think about this next iteration that we're going to be starting up for the next year and a half. And I do want to now open up the floor. I know I have at least a question for each of them, but before I selfishly take the mic, I wanted to open up the floor and see if anybody has any questions. Why don't we grab that last one in the back with Shefa?
Hi, thank you for presenting today. My name is Shefa Sikter. I work at USAID as a technical advisor on child marriage. And I have a question for Dr. Sudarshan. You were talking about some of the initiatives that were being taken in some states in India, including the training of specialists, the difficulty, the HR difficulty in getting specialists to stay in rural areas, and that some MBBS doctors were being given 4-month trainings to do a lot of specialized functions. I did all of my field work in Bangladesh, and it's the same situation. It's very difficult to get specialists in rural areas, and many hospitals were trying that approach. But at a centralized level, there was a lot of pushback from doctors, lobbyist associations, and the central government who felt that there were compromises in quality of care, and they felt threatened by this new cadre of workers. So I'm curious about how this is rolling out in India, whether it's a state-by-state accountability mechanism. And I'm also curious about this red light system that you brought up, that this red light issue of looking at procurement of drugs, and I'm wondering what the scale is, how many states this has been enacted in India.
Why don't we take 2 more, and then we will open it up for the panelists to answer. And I think I saw one up here. We can grab these 2 up here, and then we'll open it up for others.
Hi, Hi, my name is Amber Lee. I'm with the U.S. Department of Health and Human Services. I was wondering, any of you guys can feel free to chime in if you have an answer, but do any of you know about the cash transfer program in India? And if so, do you know any ways in which it significantly impacted maternal and newborn health? Thank you.
And this one right there.
I'm Indira Narayanan, a consultant for newborn health. Although it was mentioned by Geeta regarding the commodities and essential devices, I was wondering if you would not like in this, the report that has been written, the emphasis seems to be laid on essential medicines. And while they are very important, recently having been part of this life-saving commodities, I realized how many countries do not have any sustainable methods of procuring and actually supplying the devices. And I'm not talking about the expensive equipment. These are just the very basic devices. So I think this needs to come out into the vision, the visibility in each country. And the life-saving commodities groups is dealing with a very limited number of commodities. There are a larger number of these essential commodities that have to be dealt with. So I was wondering, without that, just having drugs may not solve all the problems that you're attempting to deal with.
Okay, great. So I know that Sudarshan was certainly poised to answer that first question. You got it.
Okay. There was some opposition from the Indian Medical Association, the doctors' lobby, but fortunately we have a very progressive Federation of Obstetricians and Gynecologists, the FOXY, and they are doing the 4-month course. The specialists themselves, they are promoting it, which is a unique federation, I feel. Whereas we wanted to do similar thing in anesthesia, but the Federation of Anesthesiologists, they opposed it. So we have very progressive FOXY supporting this program, and they are doing very well. So some states have done very well, some states are struggling, but it's fairly successful, and the opposition is not much. Secondly, about the Logistimo is a pilot project which we have done with the Karuna Trust and primary health centers, and in one district where the government PHCs, about 100 primary health centers and FRUs are being done. It's in the pilot stage, and hopefully we'll be able to influence and scale it up to the entire state and the national level. So we're in the process.
Did you want to? Oh,
Yeah.
sorry. I'm
Cash
sorry.
transfer, you will yeah.
So the program that Anne referred to is the cash transfer program. It's called the Janani Suraksha Yojana. In fact, there is a small box on it in the book that has been produced. Cash transfer 1,400 rupees is given to every woman who delivers at the at a health facility, which is what I was referring to as institutional births. Also, there is an incentive for the health worker, the community health worker, who takes a woman to the health facility, gets 400 rupees for taking a woman to a facility. So that's her motivation in taking women to the facility. Now, this has made a huge difference in India, and much of the institutional deliveries that have taken place, the huge increase that I referred to has been because of the cash transfer. What was happening earlier is, Dr. Sudarshan talked about the bribes and the poor governance. People ended up spending a lot of out-of-pocket expenses before, even though it was supposed to be free institutional delivery. But there wasn't an incentive to go. They spent a lot of money in bribes, in transportation, in being sent for referrals for sonograms, etc., which facilities are not there in primary healthcare centers. But today, I would say people are not out of pocket, even if they have to pay bribes and pay certain amount for expenses. They cover it from this 1,400, and there are some women who are having normal deliveries without any complications, who don't have sent to sonography and so on. So they do end up coming home with some incentive money. But apart from that, I do want to say that the quality of health services have not greatly improved, one. And the human resources have not, in fact, we have a decreasing trend in, especially as Dr. Sudarshan said, medical doctors available. So these EMOC services that have been introduced by Foxy, and by the way, and Japaigo. In fact, this was a grant I made when I was with MacArthur Foundation to Foxy to train in emergency obstetric care. I knew they didn't have the technical capacity to do the training well, so I made a grant to Japaigo here in the US and brought them in. And the government, normally, talking about scaling up, there was such a huge need given the lack of human resources that within the first 2 years, government decided to scale up literally across the country. So scaling up also happens without evidence building. But having said that, there was global evidence. And I think we've all talked about the issue of global evidence, and EMOC is something that UNICEF, UNFPA, many agencies have been involved in. So today we have, what I started with, a very globalized world, and evidence building in one part of the world can really help evidence building in other parts of the world. And the maternal health field and MDG 3, MDG 5, as well as the, I think, coming together of global health movement on taking forward the maternal mortality agenda clearly has contributed to that aspect. But I think maternal mortality would come down drastically if we could improve the quality of care, if we could, to conclude, improve the quality of care and could increase the human resources and or do more task shifting.
Margaret, did you want to take a stab at the commodities question, and then we can open it up? I know that you all mentioned some of those commodities as well.
Sure. Yes, I appreciated your point about the emphasis on essential medicines, and I think it's actually a matter of that this document is drawing on so many different events and collapsing so much information. So there is, in the discussion on life-saving medicines, the reference to certified manufacturers is, then the discussion is a shorthand in a way for discussing, as it does, the need to identify more local small manufacturers of good quality, in part to assure whatever the needs are of the health system. So not only, so there's the so that the supply is more easily assured, so that it's not, a commodity that's coming from one location that's far away and difficult to ensure. So there's more of a discussion of it in the text than I gave in my remarks.
Yeah, I can just add that I agree with you. You need a comprehensive approach, including looking at logistics management, information systems, HMIS, warehousing, supply chain management. And UNFPA is doing a lot of work through its Global Reproductive Health Commodity Security Program around all these issues that just life-saving commodities, and it's a small list in that there are many, many more. So it needs to be a comprehensive approach. So that I agree with you. Or was your question something else?
No.
Yeah.
Why don't we grab these two questions, both on the sides of Sarah Craven, who I do want to point out. She's the chief of the Washington, D.C. office, I believe, if I have your title correct, at UNFPA, and a cheerleader and advocate for the iterations that we've had these series, and I do want to thank you for that.
Hello, I'm Lillian Ibe, and I just want to commend the Global Health Initiative and the UNFPA for all that you do.
We're the Maternal Task Force, Population Foundation, lots of partners.
I'm here, I'm representing an initiative I founded, and it's in line with domestic violence. I was a victim myself years ago. So I'm more concerned about, especially women who are in that category, women who are, pregnant women who are experiencing abuse and domestic violence. Is there some type of thing put in place to be able to help them, especially with regards to midwives? Is there some type of strategy that they use to be able to get that confidentiality from them, especially, you know, when women are going through this problem and they're pregnant, they're very weak and they're scared. So, and most of the time, maybe the abusers there, they cannot give them information. Is there something that is put in place, like some type of strategy to, you know, try to make the midwife get information from them and try to also impact on them and let them know where they can get these services to be safe? Thank you.
Grab that other question and then we'll open it up to the panel.
Hello, my name is Francoise Kayuzia. I'm a founder and executive director of Action for Reproductive Health, operating in Uganda. And we are doing male involvement. We empower midwives and community members. We also empower women as well. We actually are using male as advocates for maternal health. I'm so impressed at the enthusiasm that the people in India have and the way they work to have maternal health, you know, move on. I just wanted to find out how you actually get the real data on the ground, because my experience is we do work with communities, grassroots communities. We are not yet funded, but we still work with volunteers and the community members themselves. When I try to talk to some of the people in the big organizations, and I wouldn't want to mention which, but somewhere the UN group, UNFPA, UN, WHO, it's around there, not pointing out which one it is. One of the members who I thought would be interested in knowing what is on the ground mentioned to me that when I said, can we go down on the ground and find out what is going on, she went, it's easy. We are going to get a phone, call the district office, and the district office will give us the information. However, when I went to the district office doesn't go down. They rely on other information that's given from down. So I don't know how the people in India do it in such a way that you get the real, raw information, not information from one person to the other, up to the top, and then you get an improvement in maternal health that doesn't actually exist. To me, it's extremely worrying. The other thing I wanted to find out is he talked about corruption and among the providers, health providers. It's difficult even on the top level. I do work, we partner with the government, and they have been supportive, but they can't give funds to help. It just stays in there, and we always have problems at the end of the financial year because nothing has been done. Like people from down come up and say, oh no, we actually didn't get what you people are saying we got. So I just wanted to find out whether there are possibilities of the organizations, the UN organizations and other big organizations, how they can partner with the people on the ground, the people that are really interested in having to work on the grassroots, not from the top level.
Thank you. So perhaps I'll start with a little bit of an answer regarding the question against violence against women and the impact on maternal health. I had referenced that the report does point folks to a previous event. So you may note that on April 18th, we had an event here that talked about the impact of violence against women on maternal health. And we do have an event summary online, as well as the archive video of that, where you can hear more about it, more about initiatives with midwives. And actually, that idea for that event came from the Maternal Health Task Force. So I don't know, Jackie, if you had anything else you wanted to add with regards to that topic?
I actually was going to reference the same event, but we also have a resource library on our website, and it sort of functions like a Google search, and so you can go there and pull up job aids and tools that are available on the topic, and you may be able to find some of what you're looking for related to workforce strategies for addressing issues like gender-based violence during prenatal visits.
And then I don't know, Poonam or Sudarshan, who might want to address the data on the ground question.
Why doesn't I think we can both do it, but let me quickly just say that I don't know what information you guys have, but I can say with a fair amount of confidence that the issue of violence against women has, whether it's during pregnancy or domestic violence, while we have real good data and genuine data on that, the extent to which there is domestic violence, but the public health system is not doing very much, if anything. In India, I'm not talking about the rest of, there's a culture of silence and there's a culture of acceptance, even amongst women, of domestic violence, and that's what the NFHS data shows. But in terms of data, you had a lot of questions, but I would like to say that first we collect data, what Dr. Sudarshan referred to community monitoring, and I talked about community monitoring too, that PFI is the Secretariat for Community Monitoring. What we do there is, on a whole range of indicators related to maternal health, we have a report card, which when the women come out of the health facility, they actually put, so if the service around, if they had to pay extra money, then they put a red dot. There's red, green, and yellow. And red is something wrong, green is good, and yellow is average. So on how they were treated they treated with dignity, respect, and so on, the whole range of questions. And women cannot always, write or have the time to write. So we have these dots, colorful dots, so they put it, and then those report cards are accumulated, and the data that comes out of it is put in the center of the village. But that's a community monitoring aspect. But then it is triangulated, as Dr. Sudarshan said, with state level HMIS, and also at the national level we have data now. Sure, there are, as Dr. Sudarshan himself said, there are issues with the data, but it's not totally off track. And as far as maternal deaths are concerned, because of maternal death audits, it is difficult to hide maternal deaths. The error of margin must be there, and high errors of margin. But India, we have a situation, whether it's our census data, which is done every 10 years, or it's our national data, we have pretty robust systems, and we have good institutions, independent institutions like the International Institute for Population Studies, which is actually an Indian institute, but with a lot of help from USAID, Macro, for the designing of the data. And I'm not saying for the rest of the world, but India has reasonable data, and I'm going to let Dr. Sudarshan comment on that.
Yeah,
Sorry, you're the one who has to let him.
No.
Okay. The data, as I said, especially the sample registration survey, which is done every year for infant mortality, maternal mortality once in 5 years, they are fairly accurate, but they used to be state averages. Now the SRS data is going to be district-wise. That decision has been made, so that will be much more useful outcome indicators which can be used for planning. So we also have the NFHS data, National Family Health Surveys, which are done once in 5 years. They are fairly accurate, but the HMIS data developed by the department itself, they have low reporting of the mortalities and high performance of immunization, and 150% immunization, and so you don't show the mortality. That problem is there. That's where we are saying community monitoring data will counteract that HMIS data of the health department. where the reality of the death reporting becomes much better in the community monitoring. That's why we need to take all the three together and triangulate the data.
Yeah.
That's it.
Geeta, I don't know if perhaps you want to address the corruption question with regards to possibilities for organizations like UN to get involved.
Oh.
Or not.
We don't call it corruption, we call it governance, firstly. Governance issues. Well, it's through advocacy. I don't think the UN is really positioned to interfere directly. It can't, and neither can we point fingers, but it's through indirect mechanisms, I think one very, a good robust way of doing that is through supporting NGOs and civil society organizations, because they are the traditional watchdogs, and really those organizations can raise the level. So we support those NGOs and CSOs, and they then advocate or bring about those issues. So we do it indirectly. We do not do it directly. So that's one. But your question about domestic violence and whether there are policies, and we've been thinking, because we run this big midwifery program which has been expanding very, very rapidly. And some people actually came to me. We were very focused on, looking at BMOC skills of midwives, because we found midwives were graduating without having done a single delivery. So there are midwives who, and then they go out there and, so really clinical skills and finding tutors, etc. But this point that you have raised, that they can, so thanks for again reminding me, we can definitely look at putting this into the curriculum, especially for community midwives. It's worth it, because we have a lot of programs. UNFPA has actually been dealing with a lot of domestic violence programs. We've started centers in various health facilities, trying to give them some kind of anonymity, separate through NGOs. We've been running programs for domestic violence. But I'm not really sure how far those strategies have been really successful. Again, because like my colleagues pointed out here, acceptance, one is, of course, women accept that men have, or whoever is the perpetrators have a right to, it's part of the culture. So it's a cultural change. And really, I think one place where it has worked, and as a strategy, is with faith-based organizations. In Bangladesh, there was a large amount of violence against women, huge amount. And we had a big program with the imams, almost, I don't know, I forget now, in several thousands of imams we trained, and raised the issue of, that this should not be acceptable. Would you accept it? If your daughter had this, would you accept it? And that has worked miracles. That has really worked miracles, and including in issues of child marriage, including issues of dowry, which leads to issues of violence. So addressing the root causes of why this violence is happening, and really coming out of people who have respect in the community. So if they become your spokesperson, you have to find champions in many cases, local champions who people, maybe a film star who does it, but that has effect as a strategy.
Does anybody have any last burning questions that they want to ask, or can we actually get the person we haven't heard from first, and then we'll look at what the time is then.
So just a brief statement. Nalini Singh, professor of pediatrics and infectious disease here in George Washington. Last year in the summer, I spent some time during my sabbatical and also in Fulbright. So I did, my area is infection prevention. So it was in UP, state of Orissa in Rajasthan, where UNICEF had commissioned me. The data you show is very impressive. In UP, it was in Shivgarh that I had spent some time. It's impressive to the number of deliveries have increased in the primary health care center. But from an infection prevention point of view, the services are virtually non-existent. Mm-hmm. So the privacy of the women was completely, was not there at all. So my question is, where do we go next step in preventing something very simple in terms of infection prevention? I submitted my report to UNICEF in Delhi. I'm not sure if we ever saw the light of the day. So I would just like to hear the panel's expert comments. Thank you.
And I'm going to take a little bit of moderator liberty here and add one last burning question of mine, and then perhaps everybody can then just spend a minute adding anything they might want to add on to, and then we can conclude the event. But this was a question I think more for either Jackie and Margaret, but I know one thing that was really neat about this iteration of the series was, I know we've been talking about when we look at the future, wanting to make sure that there are components of the maternal health agenda when it comes to the post-2015 development framework, for example, but I know we've, the Advancing Dialogue on Maternal Health series was involved with presentations both at the Global Maternal Health Conference, which I know MHTF had a huge involvement with, and then at the Women Deliver Conference, which I know that you referenced in the publication. So I was wondering if when we think about where we're headed, we can also, if either of you have comments on where we've been and what the impact has been thus far. So I don't know if we should just go down the table and see if anybody has any last remarks for any of the questions, and then we conclude.
Great. I think your point about our measure of success being a facility-based delivery is a very good one, and obviously that must be accompanied by a strong attention to quality of care and measures of quality of care, including the number of infections and sequelae. So very important, and gets back to, I think, our conversation, or the point about the need to collect quality data and to use it effectively. I actually, the additional point that I'd like to make doesn't respond to your question. I'm sorry, Sandeep, or doesn't respond to that. But I guess one of the things that I think is, it's addressed in the report, but I think is a bigger challenge for the maternal health field, and I think that both Lillian and Françoise referenced the role of men, because I think that yes, we absolutely must focus on women. Maternal health is a women's health issue, but we continue to be somewhat limited by a health sector perspective that is clinical in its orientation, and men and the social norms that affect decision making in households and so on are such important determinants of access and the women's sense of the entitlement to services and so on. And I see this in the family planning arena as well, that we have really got to work on developing a narrative around reproduction and reproductive rights that is somehow more inclusive of men, while still respecting the special needs and disadvantages that women face.
Okay, I just wanted to make 3 points. One is the institutional deliveries. When we said institutional deliveries, when NRHM started, it was also influenced by the policymakers here. Everybody wanted the institutional deliveries, but the NRHM said overnight we will all change them from home deliveries to institutional delivery. That was a disaster. I don't think overnight we can change from 70% home deliveries to some of the areas where it was very backward. That was the greatest mistake. We should have had a transition phase. We should accept that it will not happen overnight, over the period of 10 years, and we should have planned for both home deliveries and the institutional deliveries. Again, when we say facility, the institution, we didn't define what is this institution. Whether sub-center is the institution, whether it's a primary health center, whether it's a first referral unit, and what are the minimum standards required. So sometimes the home deliveries are much cleaner than the sub-center or primary health center delivery. So we made a mistake, and now we have realized, and that's where the NGOs are also talking about safe deliveries, and we need to define the quality standards. Infection control is very important. It's a costly experiment which we did by overnight. Everybody was eager to make it institutional delivery, and even now in India, with all that effort, there are home deliveries, and we have to accept that. Secondly, about the essential equipment, the commodities, apart from the essential drugs, the emphasis I also feel is more important. We have a very good essential drug list. In India, we have more than 100,000 formulations, but about 550 are the essential drugs for the country which is needed. And for emergency, it comes down. So we need to have a similar essential list of commodities, other equipment. Otherwise, we end up buying unwanted things, and everybody wants to buy equipment because that's where the money is. Corruption will be much higher in procurement of equipments than the drugs, so we need to be careful about that. And finally, about corruption itself, I just want to take 1 minute. The word corruption is not palatable at all, so I usually hide my presentation as good governance, as she said. But I think it's high time we talk corruption as corruption, not rent-seeking behavior, good governance, camouflage it with that. I just want to briefly mention, when I was a chairman of the task force, we had a World Bank project, and we found corruption as a major issue. And I made a remark in the when the World Bank team came, and the head of that team went and reported to my health secretary, and the health secretary wrote a 2-page letter. How can you discuss with World Bank on corruption? I was charged, though I was a chair, but I said this is a loan money, and we have every right to talk about it. But things have changed. Or now the present World Bank projects, they have transparency and accountability mechanisms. So they have accepted that. And I think we need to talk openly about corruption, which is a major issue. And of course, when the bilateral or multilateral agencies talk about it, what is needed is the authenticity. They themselves should be clean about transparency and accountability. Otherwise, they have no moral right to talk about it in the States. So I'm just saying this, some of that authenticity is very important, and we need courage to talk about it. Thank you.
Thank you. So maybe about a minute or less each. We're going to lose the webcast otherwise. So.
Okay, so I really share your concern and anguish here about the poor health facilities. We may have institutional deliveries, but the quality of care is very poor. And I absolutely agree with Dr. Sudarshan. The push for institutional deliveries, and only institutional deliveries, came from multilateral international institutions along with the AMDD program. AMDD program was really promoting and all about 100% institutional deliveries. India cannot cope with it. And what we need is linking of facility and community-based care to create a continuous care for pathway. And people like me, when within MacArthur Foundation, I said we can't do disinvest in midwives and dyes and so on. There was a huge backlash even from my own colleagues, but fortunately our president did listen. But on the whole, the winds were blowing, and that's why I really appreciate the Maternal Health Task Force supporting you and UNFPA supporting you to do national level consultations and not design programs sitting here without knowing the field realities. So we were happy to collaborate because we are fed up with systems where people sit in the US where maternal mortality conditions are first of all, you have a low, thank God, maternal mortality, but you also have facilities which have nothing to do with the poor infrastructure we have. So you can't have the same standards. Second, I want to say that ultimately, unless our governments engage, there is very little with civil society across the world sitting together in UN and other conferences. So it's a really good thing that UN, I sometimes find it annoying because you have to use words like good governance and not deal with corruption. But the fact that UN systems engage with governments, it's a good thing. And today, for any civil society organization to say that they're going to help 100,000 women even, unless they can scale up their programs, which is what is very special about Dr. Sudarshan's work, that everything he does, it's a scaling up lens across the country. That's very important. And finally, I'd like to say, as we move towards the sustainable goals, the question you asked post-2015, let's remember that there are two very important things in the 2015 Sustainable Development Goals, and one of them is women's empowerment. And I think we have to position women's maternal health and other health aspects of women, and including violence, in a maternal gender justice, dignity for women, saving lives, empowering communities, and empowering women. And unless we think on with a women's empowerment lens and use the 2015 sustainable goals, I think it's goal number 2, which is about women's empowerment and issue of age at marriage. And also it talks about giving dignity to women. And I think when we talk about women's rights and, it's such we were talking earlier with colleagues from FI, that it's such a loosely used word, but let's begin to define what that means. And it means women being treated with dignity, not just good health care in the facilities, women and empowerment. And that's why I feel I really want to put on the agenda, in my final line, reiterate on the agenda that women's family planning is a women's empowerment approach. It is not a coercive approach. It is what women want, and let's free them of the burden of having too many pregnancies too quickly, given their very fragile health.
I definitely agree with you. So how about a non-Poonam minute, perhaps, from either of you, if you have anything to add or...
Sorry.
No, I couldn't
Indian
agree.
Standard Time, I understand.
I couldn't agree more. I think really looking at country realities is key for any intervention that is planned, and there has to be a path like short-term, mid-term, and long-term, because one can't say this institutional delivery. I understand your anguish. And because we have situations like in South Sudan, with 95% illiteracy, you can't suddenly to get a midwife who's trained to competency the way we are trying. It'll take 3 years. So what do you do in those 3 years? You have to look at all the women who are delivering by, call it traditional birth attendants or whoever, and at least provide them some basic sanitation skills or some basic skills, so that at least the deaths stop there and then. So there has to be a strategic approach, short-term, medium-term, long-term, and then define what the priorities are going to be and initiatives are going to be.
In quickly closing, just to summarize what some of my colleagues have said, I think that we as a community really need to focus on scaling up our solutions through the lens of ensuring quality of healthcare services. And we'll be able to do that by creating more demand for high quality services within communities and really moving towards community ownership. And Geeta, you alluded to champions and creating and empowering more champions in the field. I can't think of a single project that I have ever worked on that did not involve a local champion making things happen behind the scenes. So let's raise their voices.
Definite good points. I do want to thank all of you for being part of today's discussion. For many of you, being part of the series that's happened over the past year and a half, and the iteration that occurred before that, which was 2 years long. So I see a lot of familiar faces as well as new. So I hope that we can all continue to stay in touch and part of this important dialogue together. So thank you for joining us.